Healthcare Coalition Response Series. Today we'll be talking about senior living facilities, COVID-19 evolving practices. We have a great panel lined up today. And before we get to the panel, I'm just going to turn the mic over to John Halamka from Mayo Clinic. And John, give us your update from the last week.
Sure. So remember, every week has a theme. And so you probably saw the New York Times article from last weekend that talked about it isn't so much that we're lacking testing, it's the fact that we have a mismatch of supply and demand. And our challenge is if you have the capacity at the Broad Institute to run 35,000 tests a day, but you have demand in Arizona and Florida, how do you solve a supply-demand mismatch? And so the one thing the article didn't highlight, and just for situational awareness to let folks know, what Mayo has done, Mayo has connections to 4,000 hospitals across the country, simply because Mayo Clinic Lab for 20 years has been a reference lab to 4,000 hospitals. So we are able to take orders for COVID tests from any of those 4,000 hospitals and then route it to labs that have the capacity to run those tests. We're live today with about 2,000 tests a day at the Broad. We're live with about 1,500 tests a day at University of Washington. And so, in fact, when the article made the statement, you can't order a test at the Broad from Arizona, the answer is you actually can. And so this is the joy of a coalition, is that we are able to work together across multiple organizations to ensure that we can deliver services by matching supply and demand. So anyway, happy to help with federated labs should there be any need. Tracing and contact tracing has been a huge theme this week, and I have been on the phone with several governors of states. And I think folks probably, FX, I would guess, have covered this in some of the other work groups, but the idea that you got Apple and Google doing their Bluetooth contact tracing, privacy protecting approaches. Though again, you probably saw the New York Times article suggesting, well, maybe not all is perfect, because on Android phones, you have to enable location services before you can enable Bluetooth. So although it's true that Google and Apple aren't following your location, you had to enable it to turn on Bluetooth. And that's causing some consternation in Switzerland and other places, and I'm sure Android will change that. But anyway, privacy protecting telemetry about what Bluetooth signals you have been close to, then layering on top of that departments of health with apps, one app per state, having the ability to turn that into situational awareness when there is a contact who is positive to notify you. There is an MIT open source foundation called the Path Check Foundation that has created the Safe Path application that several governors will be moving forward with, all open source, that is able to, in a white label fashion, take the Google, Apple data to departments of health and then provide a mechanism for notification of those who may have had contacts. And this is being used live in Germany and other countries right now. So big push on testing and tracing, especially as we see the surges in places like Florida and Arizona. And I was on a awareness call this morning. The good news is Arizona has stabilized. We're seeing a plateau. Florida is maybe a couple of days behind, but it's sort of trending toward a plateau, so we're getting there. And then the big events of the next couple of days will be a lot of work on convalescent plasma. You all know we're waiting on vaccines, but that may very well be 2021 sometime. And so getting convalescent plasma and hyperimmune globulin and focusing as a country on that as a temporary way to protect us all until vaccine has not only been a private sector initiative, but increasingly a public sector initiative. And there is now really significant interest from Operation Warp Speed and the White House in ensuring we all donate if we are capable. And I think you'll probably see over this next week quite a lot of activity and communication about convalescent plasma. But with that, of course, we have to prevent infection in geriatric and nursing home situations. So please, go forward, FX. I want to hear more.
Thank you, John. I mean, what you're describing is a lot of innovation by great and committed people in every sector. And that there's no place that's been hit harder than our senior living facilities. And so today We are very pleased to have a panel of 5 speakers, all with very recent significant experience with COVID and their organizations. So without further ado, I think we'll go right ahead. We'll hear first from Dr. Kent Bakaev from here in Massachusetts, and then we'll go to Dr. Wasserman from his practice in California, and then we'll come back to Massachusetts for our insight with our skilled facility and assisted living facility directors. So let's go right ahead, Kent. And please go ahead, just introduce yourselves as you go and let the audience know where you're from and how you got to this point today. Thank you.
Yes, sure.
Kent.
Thank you. Thank you, Dr. Campion, and good afternoon, everyone. And thank you for this opportunity to discuss this very, very important subject in relation to the COVID-19 pandemic. My name is Kent Bakaev. I am a medical director for long-term care and subacute rehab unit in Hebrew Rehabilitation Center, which is a part of Hebrew Senior Life. And I've been having pretty much, first-hand experience when it comes to managing a quite sizable outbreak of COVID-19 in our largest facility. If you're going to go to the next slide. I'm not sure, can I switch the slide myself? Here we go. So I would just would like to spend a couple of minutes to understand why we're discussing specifically this topic, COVID-19 and long-term care and subacute care in the United States. Initially, focus was on acute care, on hospital care, on ventilators. But as the pandemic unfolded, we realized that actually the major victim of pandemic has been elderly patients. And there are a couple of statements that explain why it happened. In last year, there were approximately 1.4 million individuals, approximately 3% of the United States population above age 65, who've been residing in long-term care facilities, most of the long-term care facilities in nursing homes. Close to 1.6 million patients received so-called skilled nursing care. And for our guests who might not know what it is, it's a type of post-acute care that patients receive after hospitalization, who require skilled nursing care, skilled physical therapy, intravenous antibiotics, fluids, blood transfusions, something they cannot receive at home, and at the same time they don't need to stay in hospitals for that kind of care. And usually this kind of care, skilled nursing care, is rendered in nursing homes and long-term care facilities, with average length of stay usually for a couple of weeks. So 2.3 million Medicare covered stays occurred in 2018, since some of the patients required recurrent hospitalizations. When pandemic began in the beginning of 2020, and as it unfolded in China, we've been shocked in the medical society when we got the first WHO report that reliably showed data-based mortality in China, especially among the elderly patients, close to 22%. And after that, we've heard and we've read multiple publications about outbreaks in nursing homes, in subacute care facilities, and there have been numerous speculations about the death toll. In the beginning of June, CMS has unveiled official data, and as of yesterday, more than 37,000 patients died in long-term care and subacute care facilities in the United States, which is close to 1/3 of all COVID-19 related losses. Then we can go to the next slide. So unfortunately, Hebrew Rehabilitation Center, which is a part of Hebrew Senior Life, hasn't avoided this kind of tragedy as well. We're quite sizable nonprofit multi-campus organization that mostly focuses on geriatric care in long-term care and subacute domain, with close to 620 beds in long-term care and close to 100 beds in subacute domain. Our average age is 89, and as we can imagine, our patients, especially in the long-term care section, are quite compromised from the functional and medical perspective, multiple comorbidities. We went on lockdown in the middle of March, and our outbreak unfortunately began, despite our best infection control practices, in the end of March. So 3 months forward, in the end of May, when our outbreak has been contained, it resulted in 44 losses in long-term care section. The penetration of the infection has been close to 40%. And mortality rate was close to 30%. It's been higher than average, and partially it was probably because of goals of care when it comes to our elderly patients and involvement of palliative care. It's been a major challenge for us with everything. As far as subacute care goes, there was an outbreak in our subacute unit as well, and eventually we subdivided our post-acute care into COVID positive and COVID negative. And because of high demand for post-acute care in the Boston area, we started admitting survivors, literally survivors of COVID-19 from major Boston hospitals. So close to 65 patients received skilled nursing care at Hebrew Rehab Center. Most of the patients, required ICU level of care and intubation. So what are the main key interventions we have learned being the most effective? First of all, it's universal testing. Universal testing of patients during the outbreak being crucial because it allowed us to execute data-driven decisions. And why it's been crucial is because, as we have learned in April, that approximately up to 30% of patients can be asymptomatic or in pre-symptomatic phases of the disease, but at the same time quite contagious. In many cases, we had to perform multiple rounds of universal testing on different units with subsequent strict isolation of patients, application of proper precautions. Availability of PPE and its proper use, as well as universal masking of all personnel being essential as well. We have developed close to 12 infection control policies and procedures, or modified existing ones, and has been extremely helpful, as well as overall involvement of infection control team. And of course, robust communication, education of staff. And when it comes to communication, it's not just only communication with staff, but with family members, with media, with our allies when it comes to major hospitals, absolute transparency. And of course, in the end, it was testing of staff and contact tracing. Well, I guess it concludes my quick presentation and experience.
Thank you, Kent. And I know you and your team have recently published about your experience, and we hope that that article gets widely read and taken to heart in the many parts of the country that are now experiencing the brunt of the pandemic. We'll go across country to Dr. Wasserman. Dr. Wasserman's been a leader in geriatric research and training for many years, and you had written an influential article just prior to the pandemic, and I think those words echo loudly now. But please go ahead and tell us a little bit about your experience in LA.
Thank you so much. I'm really pleased to be able to be here. So I'm medical director at one of the facilities on the campus of the Los Angeles Jewish Home. I'm also the president of California Association of Long-Term Care Medicine, which is the state chapter for AMDA. And like many of my colleagues, I think we knew as soon as Kirkland happened what was coming. And our facility literally locked down the first week of March. You can go to the next slide. So one of the things I do like to always point out, that I believe that we benefited from the fact that the first place to have an outbreak that was reported was the Kirkland nursing home. I think it sounded an alarm. I think nursing homes and assisted livings around the country locked down as best they could. Another thing it led for me was colleagues around the country in nursing homes started calling me, telling me about their situations, what they were doing to try to avoid outbreaks. And then when outbreaks occurred, why, what was going on, what was not working, what was working. And was all this enough? And the answer is no. And we know that with, look, I think it was reported at the beginning here that CMS is reporting close to 50,000 nursing home deaths. I believe that number is probably close to double that. And we just don't know it yet because we don't have all the data. So next slide. So what I want to share, and it really sort of backs up what was already stated, is our organization came out with what we call the long-term care quadruple aim for COVID-19 response, literally in early April. And I'm going to go through these one at a time. So actually, next slide. We'll start with the need for sufficient PPE. It was already alluded to, but without PPE, you cannot fight this virus. Without masks, you can't fight this virus. We're seeing it now as people are out there without masks. They're sharing the virus, especially in indoor settings. If you have COVID positive patients, you really are looking at N95s. In the long-term care setting, you cannot run out. Running out is not an alternative. It's not acceptable. Now, in the early days, in early March, we didn't know what we didn't know at the time. And I think what mattered then is as soon as folks realized that everyone needed masks and started working to get it, we encountered a lot of supply chain dynamic problems and issues like that that are still not fully solved. And so if I had to make a hierarchy, which I try not to do too much, PPE is absolutely critical because it's the one item on my list of 4 things that if you don't have PPE, nothing else you do is going to matter. This virus will spread. This virus will kill people in nursing homes. Next slide. So the next, and it was already spoken about, is readily available testing. And actually the highest priority is testing staff. Staff are the vectors. Staff are the ones that bring the virus into facilities. We knew this from Kirkland. We knew this in early March. We knew it, the CDC published in the New England Journal of Medicine on March 27th. And the importance of testing staff to know that staff were potentially transmitting the virus is absolutely critical. Obviously testing residents so you know who has it, who doesn't have it, you're able to cohort. We also know community prevalence is very important. In places like New York, the prevalence has gone down. The prevalence in the nursing homes has gone down. In places like Arizona and California, the prevalence in the community has skyrocketed in the last month or two. And guess what? The incidence of outbreaks in nursing homes has started to quickly go up. The number of deaths in nursing homes has gone up. In the last month alone here in California, we've gone from about 70 facilities that had more than 10 COVID deaths to over 100 facilities. So what goes on in the community matters because as the prevalence goes on in the community, those staff bring the virus into the facility. Next slide. Stellar infection prevention. I'm not going to go through everything on this slide. We are huge believers and supporters that every nursing home should be dedicating a full time's worth of person to the infection preventionist role. And that's for an approximate 99-bed facility. The bigger the facility, the more need. This person cannot be distracted. There is no room for the infection preventionist to be distracted. They need to be doing all the things they're supposed to do. Next slide. They also need to be training folks on all shifts, all days of the week as well. I also like to point out the importance of an engaged medical director. I believe we'll find when the dust settles that one of the best practices is having a medical director who's been leading, who's been guiding, giving guidance and support, especially supporting the infection preventionist. Next slide. And then finally, emergency preparedness mode. This is under-recognized, underappreciated, but it may be, aside from PPE, the single most important thing on the list. And that is, if your leadership team is not functioning fully in emergency preparedness mode, you're going to make mistakes. You're not going to have the right focus. You're not going to get your PPE. You're not going to realize you're running out of PPE. You're not going to do the testing. You're not going to have effective infection control. The ability to move into your emergency preparedness plan is literally a proxy for excellent leadership and management, which I believe will ultimately be shown to be a very important factor in fighting this virus. Next slide. So with that, I just want to thank all of you here. And again, I mentioned I'm with California Association of Long-Term Care Medicine. Most states in the country have a chapter from AMDA, the Society for Post-Acute and Long-Term Care Medicine. I encourage you all to engage with AMDA and your AMDA chapter and with your medical directors. It's really important. Thank you very much.
Great, thank you, Michael. That's great. I think I already have several questions I want to ask you and Kent as we get to the question part. But we'll go right ahead with Adam Berman, who's the president of Legacy Life Care here in Massachusetts, and provided great leadership during their recent pandemic fight.
Thank you.
Adam?
So yes, I'm Adam Berman. I'm the CEO of Legacy Life Care. We are a nonprofit owner and operator of 4 nursing homes, 3 assisted living residences, 2 independent living facilities, and several home care agencies in Massachusetts. We primarily care for older adults, but we also have specialized households for people living with ALS, including individuals who are reliant on chronic ventilator support. So certainly the populations we serve have a very high mortality risk with this disease. We're an organization that has long prided ourselves on innovation and tackling difficult problems. We've been early adopters of the small house and greenhouse movements in nursing homes, and one of the few skilled nursing operators to have and to provide support for people on chronic ventilator support. It's really in our organization's DNA, if you will, to rise to the challenges and to face them head on. And I say this because COVID, though we acted early, we closed our nursing homes early and did testing well before other providers were in Massachusetts. COVID provided more of a challenge than any of us really were ready for in many respects. We are not an organization where leadership or staff, are used to feeling helpless in any way. But just to be candid, there were days when that's exactly how it felt, especially early on when we were first starting to deal with this disease. It seemed like that no matter what we did, from the proper cohorting strategies to the PPE use to the incredible clinical leadership exhibited by our medical staff and our nursing staff alike, it seemed that in some parts, it was just not possible to contain the spread. The testing was too slow to come back. The PPE, though we had more stock than most, just too limited. But over the past 2 months, as things have started, I wouldn't say that they've returned to normal in any respect, but they've been stable enough to kind of create a new normal. We've been able to take stock and really, try to learn from what's happened and to prepare for the future. Thankfully, right now, we have 0 cases across our organization, but we know it will not stay that way forever. Whether it be a second wave or a continuation of a first wave, COVID is not going away. And even if records are broken in terms of time to market for a vaccine, we know that that won't be a silver bullet, and it needs to be accompanied by other strategies if we're to keep this virus at bay. I am certainly convinced that the only way to really deal with this virus is through a combination of, yes, proper infection control procedures, the usage of PPE, as Dr. Wasserman highlighted, but also testing at a scale and frequency that we do not yet have in place. This scale and frequency, and I mean things like samples potentially being taken every day from our staff, maybe at the start of every shift. They require things like pool testing, which we're far from putting into practice. Something as conceptually simple as pooling or combining the samples is actually quite complicated when most or all of the labs that we work with are unwilling to do it, and providers such as ourselves just don't have the facilities to do the pooling ourselves. On the positive side, as I try to look forward, there's really no great technological challenge here. There's no great innovation hurdle that needs to be, that we need to go over. Everything that's needed to do the frequency of testing in the scale at which we need to do it exists today. We're not waiting on a vaccine or a scientific breakthrough of any sort. It's really mostly a question of incentives and coordination. But I do believe that if we put our minds to it, we absolutely can do this and do it in such a way that we'll be able to keep people safe while increasing capacity to the extent that it's really needed. So, beyond my day job, this issue is where most of my efforts are being spent. It's really what I believe is needed to keep seniors in Massachusetts and beyond safe.
That's great. Thank you, Adam. We'll now turn to Lori Ferrante, Administrator at Elizabeth Seton Residence, a Medicare 5-star facility. And I know, Lori, you've been through much of the same worst part of the pandemic and had your own up close and personal experience with COVID, but please give us an update on how you're doing and how the facility's doing.
Great, thank you, Dr. Campion. So yes, I'm the administrator at the Elizabeth Seton Residence. I have the privilege of overseeing this freestanding, not-for-profit skilled nursing facility. It's operated as a ministry of the Sisters of Charity Halifax, and we're physically located in Wellesley, a suburb of Boston. We've got 84 beds in our facility, and it consists of 68 long-term care beds and 16 subacute short-term rehab beds. To give you a little bit of a picture of ourselves, we normally run 100% occupancy for our long-term care with a wait list, and about 96% occupancy for our rehab. So we're usually quite full and quite busy. We're also an older group. Our average age is about 88 years old. We've actually got a good history. I'm very proud of our nursing staff and crew that we have been a 5-star facility for a very long time, with a history of good DPH surveys and good infection control practices, which I mentioned because even with all of that, and given the fact that almost all our beds are private rooms, when COVID hit our building, it just hit us with no mercy. And despite all the things that we had put in place. Part of our story is, of course, we had shut down back on March 11th. So we had already closed our building to visitors, and we're essentially locked down except for our primary workers. And then we were trying desperately to get masks, to try universal mask wear at that time at the end of March. And we were not successful despite trying everything that we could do. Our vendors had cut back our supply. We were either getting limited supply or no supply. So we were trying all the non-traditional routes that everybody else was doing just to get something in the building so that we could confidently start universal mask wear and feel like we could carry it forth. We were able to do that on a Friday, and unfortunately that Monday was when our first cases were diagnosed. So we were too late with our initiative. The way it hit our building, we did have 30% of our staff who were sickened. 60% of our residents were sickened. And to give you an idea, about 35% of those positive residents did succumb to COVID. Some very rapidly in the beginning, others actually recovered from their initial bout with COVID and then succumbed in later weeks. I would say that I echo what Dr. Wasserman was putting forth. Definitely, we did have a strong medical team. Our nurse practitioners and medical director were on site almost daily, leading the charge. And a lot of what we did was really focused on communication, outreach, all the things that were already said. So what I'll mention a little bit is just, we did focus a lot on our communications with our staff and trying to keep people from being too scared, frankly, to come to work. This is not our usual state. We're usually a very welcoming, open, caring, loving community, and all of a sudden we were in the midst of this pandemic. The up close and personal that Dr. Campion referred to, I will share, I was one of the first casualties of COVID. The first wave hit us and it immediately took out within a 48-hour period myself as administrator, the director of nursing services, assistant director of nursing services, our staff development nurse, unit management nurse, very key people in the organization. We were just wiped out in the first 48 hours. We never did figure out how it got in. We'll probably never know, but it did. So a lot of what we had to contend with was communications and managing operations from offsite. It is critical to have your disaster plan in order because we did go to our continuity of operations. I actually remember the day that we went through the chain of command and we were chuckling as we got to numbers 12, 13, 14 of who would lead the facility if the other members were knocked out. It was a little bit of a joke at the time, but the reality is it was the people who were numbers 6 and number 8 on our list that were leading the facility while the director of nursing and I were communicating from home using, phone, email. Our text messages were just amazing to keep communication tight. There are a lot more to that, but those were kind of the key issues that were affecting our building at the time. I think I'll stop there for now, except to say that right now our resident population is healthy. We're in another round of surveillance testing though, and we did just learn this week, we have a couple of our staff testing positive again, asymptomatic. We just did another round of surveillance testing on residents today. So we'll see whenever we get those results back, what that holds for us.
Wow, well, thank you, Lori, for sharing that. And I know that's already generated some questions in our chat, so thank you. We're going to now move to Joe Carella. He's the Executive Director for the Scandinavian Living Center. And some of you may know Joe from his book, Creating Unlimited Options for Aging. Joe's been a passionate leader of senior living for many years, and you here in the Boston area with your facility is making it. So tell us what's the new normal like, Joe, at the Scandinavian Living Center.
It is actually very strange for us. We're a very unique place, as some of you know. We're a small traditional assisted living. The Scandinavian Travel Society of Greater Boston, we oversee the Scandinavian Living Center and a cultural center. In addition to that, and I say a very small traditional assisted living, 40 apartments, but we also have over 40 organizations that utilize the center as office space, a hub, and a gathering place. And in addition to that, we have had, up until COVID-19, over 2,000 visitors a month, not counting family or friends. So when COVID was coming, it was a strange thing. I was visiting a place called Leonard Florence Center for Living. I was going there for a meeting, and it hit me, the intuition back in early March. Their protocol was in place. And I realized that this COVID-19 was a little bit more serious. And within 24 to 48 hours, had to shut the entire building down. So for us, it's not 40 residents, it's over 2,000, thousands of visitors and over 40 organizations. Now that's where the communication was critical, because from day one, and there was a lot of pushback, because I was in the beginning of March before it was announced that you needed to shut down. A lot of people couldn't believe, they thought I was overreacting. But with us communicating right away to everybody, thousands of people, and shutting down, when COVID-19 came, and trust me when I tell you this, that the mayor's office, people in the community were calling me saying, Joe, you're going to get it. And I was like, well, no, we're isolated. We're fine. We're doing infection control. No, you're going to get it. Down the street, there was an assisted living that had over 20 deaths and over 60 positives. It was like waiting for a tidal wave. Well, when COVID-19 hit us in April, fortunately, it was only 11 people And 8 of them were asymptomatic. 2 people were in the hospital, had to go to the hospital. 1 is back. Today, we're negative all the way through. We've had 4 rounds of testing for both staff and residents. Now, in the beginning, everything was about, and rightfully so, the acute care, nursing homes, skilled care, rest homes, and they, at least in the Commonwealth of Massachusetts, assisted living was left off. So in the beginning, not only was I communicating with everybody, I was asking them to write, email, talk to the governor, the mayors, their legislators to get assisted living to be part of the testing. So we were about a week or so behind everyone, but we were very lucky to get the testing in the end of April. Now, because of all the communication, because communication, PPE is important. I agree with Dr. Lesserman. We have to have that. The testing is important. Communication for us was critical because when I was running out of PPE, looking for masks, looking for everything we needed, because once you have the positive, it's a new world, as most of you know. I had people, I would just send out communications. I need masks. I need this. They would literally show up in our front door from family members. I was talking to people in Amsterdam, Korea, China, everywhere, like everyone else. But the community, because we were so connected to the community, took care of us. Vans would show up with boxes of gowns. I was down to 1 gown. So I think the experience for us is that even though we're in assisted living, and our community-centered living, which is our philosophy, has been put on hold, all of us understand now what it's like to be isolated from community. It affects us more because we're so used to having people, hundreds of people a day, which is just, now there's nobody. So I think the communication is critical. I think families are getting lackadaisical. I think the community in general is feeling like, oh, this is not a big deal. I literally had someone yesterday tell me that if someone tested COVID and they were asymptomatic, they weren't going to spread it. So there's a lot of misinformation. And I think the critical thing with communication is we need to be on the same page with the same information. And I absolutely feel that testing needs to continue. At the assisted living level, I would be happy once a month, because once you show negative, you need to maintain the staff. And I would do more than that if we could. So there's our story, our unique little story. Thank you for having me here today.
Thank you, Joe, and thank you to everyone. So I'm going to have all the panels keep their video on and allow them to ask each other questions. And one that came up in the chat is just about morale, and how do you maintain morale in a setting where there's so much, there can be misinformation, but people are genuinely scared for themselves and their family members. So just whoever wants to start first, just give me some of the pearls of wisdom that you've learned in the trenches about communicating with your staff and the family members of your residents and your residents.
Yeah, well, we've been, and I mentioned during my presentation that we've been absolutely transparent. We would report on our website on daily basis how many cases we had on what units. We would send out daily communication emails to our staff members. Doesn't matter, be it security team, be it IT team, be it obviously clinical front staff, so people can make informed decisions. And of course, communication with the staff in terms of education, that if you have symptoms, please don't report to work, education about proper use of PPE. As we were getting literally daily updates in terms of understanding clinical and epidemiological behavior of the virus, we would keep that education going on a daily basis.
I just want to highlight what Joe said. Communication is everything when it comes to staff morale. And I have colleagues at facilities that had outbreaks, and everyone was worried about testing, because if you find out people are positive, what are they going to be worried? And the opposite is true. If your staff know you're being honest with them and upfront and transparent, you will have better morale, you will have better, everything will be better. And we got to run towards effective communication and health literacy rather than run away from it.
I would certainly agree with all of that. Part of what we found with our team was not only were they afraid of the virus itself and wanting to understand that, They were also afraid, if I'm out, am I going to use my sick time? Am I going to get paid? What about my job stability? There were people who didn't want to get tested because they were afraid that if they were positive, that meant they couldn't work. They'd have to use their vacation time or they wouldn't get paid. So we, very early on, before it was even mandated, we were telling people, no, that's not how it works. We made sure they understood there was no penalty. They were going to get paid. It was from different money. It wouldn't affect their vacation fund, that they needed to be out. And we made it very clear, this is the best way to protect our residents. And we put that front and center. We want you to understand you are the front line. You're protecting the residents. And so you've got to let us know. If you don't feel good or if you've got even a mild cold, don't come in. You will get paid. And that really worked very well. We also did institute hazard pay for all shifts so that everybody, no matter what your job was, if you showed up, you got hazard pay. We were paying by the shift. And then additionally, when we had COVID active in the building, people were paid time and a half for everyone who was actively working literally on those units, in addition to the hazard pay by the shift. So they knew that we were putting our money where our mouth was, which was important. That coupled with the transparency of communication, and we have a reputation already for being transparent. That's our culture here. We are, I think, a fairly trusting kind of place. We've built that over time. But in addition, we used both constant contact email blasts that went out to all the employees to their personal emails, as well as to the families, by the way, we use that as well. We also have a text system that goes to all the employees. We could also text out pertinent information to subgroups. I know different groups were doing morning huddles as well each day, letting the staff know what they were facing that day, if there were new cases, new changes. So everything that we could do to try to calm people, figure out what were they afraid of, we tried to address head on.
I would add that we did what, Laura, we did what you did. And the craziest part was the families and the community, because we were so connected. They were sending food, gifts, gift cards. We gave the heroes pay for the people that worked. And then everybody else just jumped in. And I'm sure some of you have experienced it, the staff appreciation as a nonprofit. We set that up right away and people were donating. But I got a big kick out of gift cards, flowers. I had couple of family members that wrote a letter to every single staff person. So that helps because they knew we were all in this together, and it was pretty special to experience that. So it just reinforces the importance of that community-centered living. I miss it. I miss the community, but they're there for you when you stay connected.
Mm-hmm.
I can't hear FX. I think
speaking about the testing, I know different states have gone about testing programs in a variety of ways. In Massachusetts, the National Guard was brought to bear to help provide testing to skilled facilities, and that was good for a little while. But talk about what you expect going forward. How are we going to get this paid for? What's a reasonable frequency of testing? How do you proceed with testing for staff? How do you proceed with testing for residents? And then what are the precautions that you have to take when you do have a positive case?
So I'll jump in. This has been literally my #1 topic since March. As a clinician, I look at this clinically first, and we must be testing. We must be testing staff, because if we don't know that staff's bringing it into the building, we're missing our transmission vectors. It is, in order to open up and allow visitors and ombudsmen and surveyors and whomever into the buildings, they need to be tested too. And so it's absolutely clear that the ideal situation, the gold standard at this point, would be point of care testing with very rapid turnaround. And that would allow us to do so much better. CMS we'll see what happens, has said they're going to be sending tests, antigen tests out to nursing homes. The antigen tests are not as sensitive as the PCR testing. However, if you can literally do on-site tests of your staff every day, the sensitivity will go up with multiple tests. So I'm intrigued to see what happens with this. And when it comes to funding, look, my view is we need to care about taking care of the residents and the staff, by the way, because when the residents get sick, so do the staff. When residents die, so can staff. I think as a society, you know, we're spending billions on a vaccine. Why do we as a society always need a pill or a vaccine? What about prevention? And testing is part of prevention, just as PPE is part of prevention. So I think federal, state, local governments need to look at how they support testing. And you know, that's a policy decision for the policymakers, but I think it's time they step up and do their jobs.
I second the testing. I think we need to increase the testing and make it accessible. In the Commonwealth, they kind of shut it down a little bit and left it up to us and given us a list to connect with labs. I have test kits. I have no lab to go to. But what I found for new people coming into the building, our residents who've gone home since April, just the first test and come back in, I asked them to get tested within 72 hours, but the day they come in, I've hooked up with a company that will test them right there that day. So instead of putting them in isolation for 14 days, we put them in isolation until we get the results back within 24 to 72 hours. But there has to be testing for everybody, any elder type of population. We have to test the residents and the staff ongoing. And it's expensive and we have to figure out where to get the funds, but I second the testing. We may not have the vaccine for 6 to 8 months, but we have the testing. It just needs to be organized and the communication has to be correct, or one voice, not too many messages, because there's so many false information out there.
In the testing, at least in the skilled nursing world, this is different for AL or for assisted living. It's primarily state by state. There are, you know, CMS does have some directives, it's more guidance to state officials, but it's really the individual states that are coming up with their own policies. So in Massachusetts, the policy that we have for surveillance testing is that we have to test 30% of our staff every 2 weeks. Then if and when a positive is, you know, comes from this, then it jumps up to 90% for a minimum of 2 weeks, 90% of all staff and residents for a minimum of 2 weeks, or until such time that there's no longer a positive in the building. So that's Massachusetts's policy. I'm in favor of it. In full disclosure, I was one of the authors of it, so I am a little partial to it. It's worked, hopefully it's going to work well, but there also is certainly, to Joe's point, providers are somewhat on our own in trying to kind of coordinate all of that. And larger providers have the capacity to do so on a large scale, but that 90% requirement is especially difficult when the National Guard is not available. So it is something that is very dispersed right now in a way that is not always to the benefit of the residents that we serve.
Adam, can you talk a little more about that program? Is there funding associated with it? Is it a best practice, or is it a requirement? Do you have to report to the DPH at all?
Yes, so we have to report all of our results to the Department of Public Health, and so actually the labs themselves have to as well. The funding, there's funding associated for staff, not for residents, because the expectation is that the residents have insurances that they can bill. But for staff, at least for surveillance testing, Massachusetts is offering $100 a test. And that is generally considered sufficient. It wouldn't have been 2 months ago when there were tests out there for $300-400, but the price has come down substantially, and we have been able to find testing providers that will work with us for $100 or less. It does require, in most cases, for the facilities to do their own specimen collection, which many nursing homes are able to do, though when you're short-staffed because people are out from COVID, it is very resource intensive to be put in that position. But I'm very concerned about assisted livings, of which we have some ourselves, and other more ancillary providers, because even if they have nursing staff, they may not have the capacity to do swabs for all of the staff in the building, for example. That's one of the reasons why I'm excited by, the potential use of saliva, which we're looking into right now, which could really help with staff specimen collection. Because, one of the bottlenecks through this, at least over the past couple of months, we've seen in Massachusetts, has been more on the specimen collection side than actually on the processing side, because we have places like the Broad Institute that can do, 100,000 tests a day. And that really hasn't been the issue. It's been more on who's actually going to do the swabbing and the specimen collection.
Great. I know the concept of pooled testing came up where you would actually combine samples from multiple individuals, say multiple staff members. And is it possible, Adam, that you could go up from the 30% of staff every 2 weeks to getting a much higher percent of participating in a pooled sample?
Well,
and would the economics be more favorable for that?
If we could combine pooled testing with saliva collection, which could be something theoretically a staff member comes in and while they're having their temperature taken, they also spit into a cup. If that could then be pooled, and that's really actually the issue that we're running into when we take a look at this. There was a question that came up from someone asking why labs are reluctant to handle pooled tests. And it's not so much, at least as far as I know, that the labs are reluctant to handle the pooled tests. What they're reluctant to do is to do the pooling themselves, to take the multiple specimens and actually putting them together. And nursing homes do not have the capacity, assisted living certainly don't have the capacity or the facilities to do that work. The labs themselves, as I understand it, have sufficient demand right now, at least some of the larger ones that would have the capacity to do the pooling. So they're just frankly not incentivized right now to actually set up the additional processes necessary to do that type of pooling. But if you can combine, you could see, for example, if you have 3 floors in a nursing home or an assisted living, if everybody working on first floor was pooled together, they came in for their 7 to 3 shift and you had 10 people's specimens pooled together, and that's processed, and one comes in, it comes back as positive, then you go back and you run them all individually. But yes, the economics are far more favorable to do something on a daily basis, unless if we can get really, really inexpensive point of care testing. The economics, I think, of pool testing alongside saliva specimen collection is what I think has a lot of promise.
Great. And just thinking about, what's possible. We have a lot of capacity within the coalition, and just wondering if any of the members on the panel were aware of a best practice where there was, say, a pool strategy written out or a protocol put together. I think there's probably interest in the coalition to help support you with that protocol. So please, I'm hoping that after our short time together today, if there's a earnest interest in moving forward with any of these ideas, feel free to get in contact with me, and I'll help to introduce you to the folks within the coalition who may be able to help.
And there's a group out of Berkeley who are working on this, so to connect those people with you and everyone, I think would be very helpful and well received.
Okay, that's good to know. Yeah, if you have any information on that, just put it in the chat and we can share it. There is a question in the chat from one of our colleagues involved with care in Jerusalem, and asking specifically about the managing of religious practices during the COVID pandemic. So that's from Dr. Schenker. I just wonder whether anyone has insight there.
Yes, well, Hebrew City Life is obviously based on Jewish traditions and values of Judaism. So unfortunately, once the pandemic began, we had to shut down our synagogue. However, we still continue socially distanced events, if I can say so, especially when it comes to Shabbat on Friday afternoon. Sometimes, not sometimes, but pretty much virtually, it's been done remotely. And we've been utilizing FaceTime and Skype and this kind of technology services with to some extent. So and last, we've been fortunate that our spiritual services unit has been very much involved, be it chaplains, rabbis, and they've been part of the palliative team and they've been providing spiritual care, especially to patients and families who are in the highest need.
Now, I also wanted the second question, as part of her question, was on the flu, and I've got to say, there's some folks are talking about what do we do now when flu season hits. My bias on this is we have never focused as we have on infection prevention like we must focus during COVID. I think there's data from Japan that showed as their flu season was there as COVID was ramping up, that they had a decrease in cases of flu. So look, I hope that our attention to stellar infection prevention will actually help tamp down the flu season.
I agree.
I have one other thing I'd like to just add with regard to the religious practices, because we're a Catholic home, and welcoming people, though, of all faiths, of course. But we've used our closed circuit television system for many things, including making sure that we're addressing some of the religious and spiritual care needs of the folks. Here on campus, we do have a large chapel that is normally utilized, and of course we haven't been using that, and there have been no gatherings. But utilizing our closed circuit TV, we are able to broadcast prayer services. I know our chaplain has worked with other folks to do programming that is specifically of interest to our residents. And we've actually used closed circuit for lots of things and activities too. If people are looking for other ideas besides just tuning into YouTube all the time, if you take your own staff and you put them on your closed circuit TV, you can lead activities, exercise programs, you can do cooking with the chef, you can do all these other things. Someone else had asked about, people staying connected. We used our closed circuit TV and still do for many kind of things, and we just keep coming up with new ideas on how to do it. But that's been real important. And of course, the chaplain was very, very key in dealing with our folks all through the thick of this, both our residents and our staff.
That's good. I know the mention of PPE at the very beginning as the critical success factor. I just want to get a sense for what the PPE outlook is now in your facilities for anyone on the panel.
As long as we have 0 cases, we're doing okay. I actually say that in jest because we actually use more PPE when we have 0 cases than we do if we had an outbreak, to be honest with you.
Right.
But it is sufficient for us right now. But if you're not in a position right now where you're not over ordering, I would be very concerned. It shouldn't have to be this way, but we certainly are stockpiling in the event that a second wave or the continuation of a first wave does come.
Right. I think it's still the N95 masks that continue to evade us. We just have a handful. We've never been able to get a significant supply. So we've used the KN95s, but it would have been nice if we had had the N95s. People are more trusting of that. It just feels more secure, but otherwise we're doing all right. Same thing, hoarding and stockpiling.
Yeah, we're definitely in much better position when it comes to PPE. However, I have to say that we still use PPE quite extensively, and the reason is that according to our infection control policies, when we admit new patients from hospitals, until they're tested 3rd time negative, because our requirement is to be tested twice negative within 72 hours before the discharge from the hospital, and then we retest them one more time upon admission, and it usually takes 12 hours for the test to come back. So until we get the 3rd test negative, we approach patients as presumably positive, and we use full PPE. The same with the admissions from the community. When we admit patients to our transitional unit, where they stay for 2 weeks, where we test them 3 times, look for symptoms before they go to their final long-term care units, we also approach patients as presumably positive, and we use full PPE, including face shields, N95s, gowns, gloves, plus obviously proper hygiene. Somebody asked a question about whether we use N95s. Yes, we do, and we also provide, UV sanitation of N95s, and we collect N95s from our front clinical staff, sanitize them, and then put them in circulation. But we usually don't use N95s continuously more than, I would say, 10 days.
Great. Well, this is just a fantastic conversation, and our hour is already come to a close. So I just want to congratulate each of you for your tremendous work and effort and the leadership you've shown in your own communities. Thank you for taking the time today to share with this group. And I hope this is just the beginning of potential future collaboration. I think we're particularly interested in helping you or having a continued dialogue about best practices. So thank you very much, and we'll keep the chat open for a little bit, but we'll all sign off otherwise. Thank you all.
Thank you.
Thank you.
Thank you.
Thank you.